Hello everybody, can you hear me? Okay, so in the cancer domain, our case study today is about pediatric cancer. We hope you'll enjoy the presentation. We've done a bit of a film and animation that hopefully you'll enjoy. Certainly we enjoy putting it together. But first I'm going to set the scene a little bit. And I'm going to start by talking about this boy here. He's a bit of a poster boy at the moment in America. So he's called Noah, and he was born in 2007. And he was a pretty fit and healthy young boy for 4 years. And then all of a sudden, he became quite unwell. Very pale, tired, didn't want to go out with his friends. And he became really profoundly unwell extremely quickly. And the doctors quickly diagnosed him with an aggressive form of acute leukemia. And thankfully, because of the drugs we've got now, he was able to be cured. And one of the reasons that he's become famous is because of this photographic juxtaposition here, which is the reverse of what we normally see. On the left, he's there when he was 4 years old in 2011, when he was at the height of his illness. And on the right-hand side, you can see him about 2 or 3 months ago, cured. And not only cured, he also has a normal quality of life. Okay, but one of the uncomfortable truths about this is 10 years ago, certainly 20 years ago, he would not have survived. So you might be wondering why we're at a Manchester conference. I'm talking about someone from the US. Well, I'm mentioning him because it's the international reach of some of the cancer research that's gone on in Manchester through the university and the Christie in particular that have allowed people like Noah to be alive today. Now, we know that cancer in children is quite rare, but cancer itself isn't rare. About 1 in 2 of us will probably have cancer in our lifetime, and 1 in 4 of the people in this room will die of cancer if the current statistics continue. And every one of the people in this room will have been personally affected by someone with cancer, either a friend, a work colleague, a close relative. So we've all been affected by cancer. But I want to talk a little bit, not about the negative bits of cancer, but the positive bits. I want this bit of a presentation to be a celebration of what we've done in Manchester. And I'll start with this slide. The Christie, again, I'll mention, and the university have led an enormous amount of world firsts in cancer over the last 100 years. Developments such as radiotherapy, image-guided radiotherapy, breast cancer treatments, prostate cancer treatments, you name the condition, someone in Manchester will have done some kind of key clinical trial in this area. The one that I single out there is tamoxifen, still being used throughout the world. First clinical study here in Manchester. It has saved hundreds of thousands of lives across the world. It's now being used for prevention in breast cancer, so an amazing drug. So to clinical outcomes. You saw a slide from Ian showing how woeful we are doing at cancer, but I'll show you a different perspective. This is much short-term data, so the other data was perhaps more reliable. But if we look at the 1-year overall survival, the graph at the bottom there is this one here is Manchester. We were significantly behind the other great cities of England in the last 10, 15 years, and we've closed that gap. And you can see there, with an eye of faith, in the 1-year survival, we've now started edging ahead of the rest of England. And if you put that in context, in 1990, the chance of you surviving more than a year after a diagnosis of cancer was 50%. Now 70% of patients live for a year or more with cancer. But let's not get ahead of ourselves. Sweden's the world's best, and they're 12% ahead of us in England, everywhere in England, 12% ahead on the 1-year survival. So we've got a long way to go. So this is a slide really to give an overview on a very simple level of our strategy for Manchester for cancer. At the top we have a renewed clinical strategy, and this is the umbrella organisation here is Manchester Cancer that I'm part of, and there's many people in this room actually who are also part of this organisation. It's an umbrella organisation where the acute providers of cancer care in Manchester, across a population of 3 million, have all agreed to work closer together. So we've got hopefully seamless clinical leadership and everyone agreeing to the standards and the other things that we want to do for cancer, focusing on outcomes as opposed to the processes that we followed with the previous peer review system, and also focusing on patient experience and clinical innovation. And at the bottom too, we've got a kind of comprehensive, cohesive collaboration for research. This is the MAHSC Cancer Research Centre. There's 3 key partners here, University and the Christie, but also Cancer Research UK. And together they have created an enormous amount of investment into research, which really spreads the whole spectrum of cancer research, from cell science through to translational research. Maybe we'll touch on that a bit later. But really, what's MAHSC's role in this? I think MAHSC's role in this is to try and bring this clinical community and the research community closer together. So I think that's what MAHSC should be doing in this setting. And if I could just give you a little bit more depth about our strategy, this is currently what happens in healthcare and in terms of improving healthcare. And this will be the same, I'm sure, in all the domains that we talk about today. On the main bubble there is a standardization bubble. So most of the efforts in healthcare improvement is reducing the unnecessary variation between clinical teams. Very little is put into prevention and personalisation at the moment. And certainly for cancer, the prevention is really quite an anachronism, really, because we know Cancer Research UK suggests that 4 out of 10 cancer diagnoses could have been avoided by simple lifestyle modifications. 4 out of 10. And yet we only spend 2 to 3% of our healthcare spend on prevention. So maybe we've not got something right. Also, we haven't got the money to carry on doing healthcare without spending more money on prevention. Over the next 10 years, certainly 20 years, I think we're going to see a significant shift in the emphasis and where we're going to see our improvements. You can see here that the standardisation is still there, of course, but the prevention bubble has substantially increased, and the bit that particularly the scientific community are leading on is this personalisation. This has come about largely because of the unravelling of the genome and all the opportunities that creates for people to have bespoke drugs made for them so that their particular cancers can be treated effectively. And there's a number of things that come together to allow this strategy to occur. The main one is collaboration. So I've described collaboration increasingly happening between the secondary care providers, these are the hospitals, but we also need more collaboration between primary care and secondary care, and it's good to see that there's a political initiative to help that, along with making us work more with public health. But I think the real collaboration that needs to occur is the scientific community and the clinical community really do need to come together. The other thing that we've been able to achieve so far, but we'll need to keep emphasising this, is money and effort into infrastructure and also key people. There's a 37 million spend going on to recruiting international scientists for cancer. That's currently midway through its recruitment programme, so that's quite exciting for Manchester. And also there I put a little picture at the bottom left there about pills. That's really to represent industry and other partners, learning organisations. We have to work with other partners to give us money and help us develop things, pharmaceutical companies in particular, but also other learning organisations. And we've set up links with many places like UCL, Cambridge University, Belfast University, and other international collaborations to help us achieve our goals. So this is my final slide before I show you the animation. You'll see this around the conference today. This is our headline infographic showing our main aims. Perhaps the most eye-catching is the one on the top right. So you might remember I said that at the moment 70% of patients survive 1 year with cancer. We want to make that for patients diagnosed in 2020, 70% surviving 5 years. So that's our main aim. Okay, I'm going to start our animation in a second. Hopefully it will work. It does touch on a couple of themes. They are the standardisation and personalisation. And I think it also speaks towards the end about our social responsibilities that we have as healthcare innovators. So hopefully this will work.
Hi, I'm Lucy, and I want to talk to you about what Manchester's MAHSC doctors and scientists have been doing about children's cancers. Did you know that after trauma, especially from road traffic accidents, cancer is the UK's biggest cause of death in children and young people under 20 years old, with 330 deaths per year. The cancer which is killing most of our children is leukemia, or cancer of the white blood cells. The most common type by far is acute lymphoblastic leukemia, or ALL for short. In ALL, the bone marrow is quickly taken over by cancer cells, and without treatment, children will die within a few months. Back in 1980, only 5 out of 10 children who had ALL survived. With changes and advances in treatments, by 2010 this has increased to approaching 9 out of 10 children surviving. This means that every year in the UK we are saving 150 children's lives compared to 30 years ago. What a fantastic achievement! Did you know that Manchester has been at the forefront of developing these improvements? To understand how this has developed, we're going to have to go back in time. Back in the 1960s, Dr. Jake Stewart from Manchester University recognised that the needs of children with cancer are different to adults, and he set up the first dedicated children's tumour registry in Europe and had children's cancer identified as a medical speciality. By the 1980s, all the current cancer drugs in widespread use had been invented, but were not being used in optimal ways. Remember, at this time only 50% of children were cured. In the 1990s, Professor Tim Eden, the world's first professor of teenage cancer medicine, who worked at the Christie and Manchester University, led the way. He did studies which worked out which drugs worked best and what dose. This approach is called standardisation and was a huge success. More recently, the same Manchester team working with international partners have developed a different approach, particularly for patients identified as being at higher risk from the disease. By breaking patients with ALL down into different prognostic or risk groups, it means that there can be different standardised treatments offered. This development is one of the first examples of personalisation of treatment in cancer. It means that high-risk patients get different doses and, more importantly, more children are cured. The advances that Manchester had worked on continue. Manchester doctors co-authored a New England Journal of Medicine study of 40,000 children with ALL, followed up for 10 years, and noted that their outlook varied hugely depending on the appearance and changes to certain chromosomes, especially chromosome 21. By increasing the dose of methotrexate in these patients, our doctors have been able to significantly improve outcomes. Manchester scientists have also recently demonstrated a novel biomarker called AEP, and it turns out this is important in Alzheimer's and heart disease as well as ALL. Other very recent developments, co-led by Manchester, has been 2 separate international studies showing that in certain patients who develop a relapse of the disease, newer drugs called imatinib or mitoxantrone can be added, which dramatically improve survival. One of the key current projects led by Professor Saha is to build strong links with cancer centres in India, where the outcomes for patients are much worse. While our ALL cure rate is 90%, in India it is at 50%. By working with drug companies and local Indian doctors, the ambition is to improve survival rates to 75% by 2020. This will mean an extra 2,500 children every year in India being cured of the disease. I hope you have enjoyed the story so far. You can see that there are many more children alive in the world today because of the work and ambition and drive of Manchester's doctors and scientists. I am proud to live in a city where treatment and research into cancer is such a priority. I think this is worth celebrating. Thank you, Manchester, and thank you, MAHSC.
David, that was just fantastically inspiring. A round of applause to David and for that film. Yeah, come on up. Yeah.
So this is Professor Saha here, the star towards the end of the show.
Very, you know, I saw you looking at your picture up there. Fantastic, the work that you're doing and the potential that you've got. I mean, I did think the tamoxifen statistic, it's just on its own, it's just something that should be taught in every Manchester school, isn't it? Hundreds of thousands of lives saved due to the work right here in this city. Thank you very much indeed for your presentation. Thank you very much. Very nice to meet you. A round of applause for the cancer team.